Bismillahirrahmanirrahim. I am Dr. Sayyid Raza Muhyiddin, member of the visiting faculty for MPH classes, Time Institute, Multan. And this is the third lecture on healthcare systems analysis. And today we will discuss the different indicators of health. So, as I already told you, the health is defined as a state of complete physical, mental, social and spiritual well-being and not merely an absence of disease or infirmity. So, by this definition, it includes the ability to lead a socially and economically productive life. So, what are the indicators of health? Indicators are also termed as index or variable, and it is an indication of a given situation or a reflection of that situation. So, health indicator is also a variable susceptible to direct measurement that reflects the state of health of persons in a community. And this helps to measure the extent to which the objective of the targets of a program are being attained. And numerical indication of the health of a given population derived from a specified compositive formula. So this health status indicators, they measure different aspects of the health of the population. Examples include life expectancy, infant mortality, disability, and chronic disease rates. And the health determinant indicators measure things like influence health. This includes diet, smoking, water quality, income, and access to human services. So health indicators have different characteristics. So there are 6 characteristics of health indicators. They must be valid, reliable, sensitive, specific, feasible, and relevant. Now we will discuss what are the different uses of these indicators of health. The health indicators are used for the measurement of the health of our community. Then it is description of the health of the community. First is we measure the number, then there is a description of the health of the community. Now the third one is the comparison of health of different communities. And fourth one, identification of health needs and prioritizing them. First we see the needs and then we prioritize them. And the fifth one is evaluation of health services. What we are providing to the people, we just evaluate it. And then very important is the planning and allocation of health resources. Through our indicators of health in different communities or in different countries, the health resources are being indicated. And then is the measurement of health successes, what you have done for the health services. By if the indicators of health are improved, they go on the positive side. We say the measures taken are positive, they are towards success. So we, by the indicators of health, we measure the health successes. Then the indicators of health have different sources. The census is number one, and then is the sample registration system. This is annual information, national and state level, and now then there are sometimes the National Family Health Surveys, district level household and facility service, and by these different surveys and obtaining of data from different registries, the health indicators are being measured. Now, there is a broad classification of health indicators. There are mortality indicators, morbidity indicators, disability rates, nutritional indicators, healthcare delivery indicators, utilization rates. Then are the indicators of social and mental health, environmental indicators, socio-economic indicators, health policy indicators. Then are the indicators of quality of life, and there are other indicators which are not listed in the previous. I told you the indicators. So we will discuss all this briefly one by one. And firstly are the mortality indicators. So in mortality indicator, the first one is crude death rate. So it is a fair indicator of the comparative health of the people. So it is, you have also read in biostatics as well, that it is the number of deaths per 1,000 population per year in a given community. In really a mid-term population is taken. And its usefulness is restricted because it is general, and it is also influenced by age-sex composition of the population, and also by the socio-economic and socio-cultural communities. So then is the expectation of life. So are the, it's the average number of years that will be lived by those born alive into a population if the current age-specific mortality rates persist. There is a current age mortality ratio, and from that the expectation of life is concerned. And it is a statistical abstraction based on existing age-specific death rates. And this expectation of life is estimated for different genders, especially for males it is different, and for females it is different. And it is a very good indicator of socio-economic development. If the expectation of life is greater, that community or that population or that country is socio-economically well. And then you see the life expectancy at birth. So in male it's 64 years, WHO Global Health Observatory in the 2012 formation, and the females are 68 years. Then there are other mortality indicators, and these indicators are very important, and mostly, count a lot towards the health indicators and for development programs and for monitoring those programs. This is the infant mortality rate. It is the ratio of deaths under 1 year of age in a given year to the total number of live births in the same year, yearly expressed as a rate per 1,000 live births. 1,000 live births are the denominator, and the death rate under 1 year is the nominator. So you get the infant mortality rate. In some times it was very high in the underdeveloped countries, especially also in Pakistan. Now it is decreasing due to maternity and child health services. This indicator of health status of not only infants but also whole population in socio-economic conditions. And this is a sensitive indicator of availability, utilization and effectiveness of healthcare, particularly perinatal and postnatal care. The women and children are in the previous years, they were very neglected segments of the human society. Now still, in certain countries and of course in the villages, the women and children especially the female children, are the neglected group of at risk groups of the communities. Now, like infant mortality rate, it is under 5 mortality rate. So under 5 mortality rate is defined as number of deaths occurring in the under 5 age group per 1,000 live births. And this reflects both infant mortality rate and child mortality rate. And this, this is very important because it indicates the perinatal services during delivery of the child, and of course the nutritional state of the children. Then is the child mortality rate. It's very close to under 5, which is the number of deaths at ages 1 to 4 years in a given year. So this is something, under 5 mortality rate minus infant mortality rate, and this same with per 1,000 children in that age group at the midpoint of the year. And this is, this 1 to 4 years mortality rate is purely concerned with the MCH services, malnutrition, low immunization coverages, and environmental factors. The factors which are not conducive to the development of the children. And the other indicators are perinatal mortality rate, neonatal mortality rate, stillbirth rate, etc. This all correlates with inadequate antenatal care and perinatal care. And all these words, perinatal mortality rate, neonatal mortality rate, and stillbirths, they are, as per the name indicates, this reflects their definition. So this was all concerned with the infant under 5 and 5-year age children. Now is another very important mortality indicator is a maternal mortality ratio. As I told you, the females population is at risk population. There is neglected segment of the society. So it is the maternal mortality ratio is ratio of number of deaths arising during pregnancy or puerperal period per 1 lakh live births. So here the denominator is, greater, and the deaths are taken when a woman becomes pregnant, or it is during delivery, or whether she is in puerperal period. And puerperium, you all know, it is a period after delivery, 40 days or 1.5 months. Then this accounts for the greatest number of deaths among women of reproductive age in the developing countries. Then is the disease-specific death rate. As the name indicates, is mortality rate, which is computed for specific diseases. Then is the proportional mortality rate, is the proportion of all deaths attributed to the specific disease. For example, coronary heart disease causes 25 to 30% of all deaths in developed world. So this is a proportional mortality rate for coronary heart disease. Then after mortality indicators, we have morbidity indicators. And in morbidity indicators, this reveals the burden of ill health in a community. In the previous semester, I told you about incidence and prevalence. So these were the morbidity indicators, but they do not measure the subclinical or inapparent disease states. So the morbidity indicators, the first is incidence and prevalence. As you all know, incidence is the number of new events or new cases of a disease in a defined population within a specific period of time in a community, and then you have different incidents of the diseases in different countries, in different areas, in different times. Then prevalence is the total number of all individuals who have an attribute of the disease at a particular time divided by population at risk of having attribute or disease at this point of time. So it reflects the chronicity of disease. Incidence is for the new cases and prevalence is the total number of cases. And then are the notification rates. They are calculated from the reporting to public authorities of certain diseases, for example, poliomyelitis, etc. So all the people who are working in OPDs and have their own clinics, they know that they have given the form when a patient of so and so diseases are notifiable diseases. They come across those diseases. They just report to the health authorities. Like if a corona case nowadays is seen in a private clinic, he immediately reports to the health authorities. Or if your lab is doing corona test and he finds a person positive, the copy of the report or information is sent to the health authorities. Then are these notification rates provide information regarding geographic clustering of the infections and then quality of reporting system, etc. Then there are attendance rates as OPTs and health centers. Then these rates are, as the name indicates, there are number of patients with different diseases who attend to the hospital OPD. Then there are indicators of admissions, readmissions and discharge rates in the hospitals, different hospitals. Then there is a duration of stay indicator, that for how long a patient stayed in the hospital. Then there are spells of sicknesses or absence from work or school. So it's a difficult indicator to note, but in the developed countries, they have got the data that how much persons in a community were sick and they were absent from their work or from their education centers. So this reflects economic loss to the community. If you know, if a laborer, if a cultivator is sick, he is not contributing to the economic growth. So economic growth will stop. Then there are hospital data. This can constitute the basic and primary source of information about diseases prevalent in the community. So all this is their morbidity indicators. Now, a very important indicator of health are the disability rates. They are of two categories. The one is event type indicators and then is the person type indicators. In event time indicator, number of days of restricted activity is measured, are the bed disability days or work loss days within a specified period. And again, I told you by this is a economic loss to the GDP or to the economic growth. Then are the person type indicators. This is limitation of mobility. For example, the one is confined to bed, confined to house, special aid is getting around. If limitation of activities, limitation to perform the basic activities of daily living, for example, eating, washing, dressing, etc. Then there are two important disability rates. The first is Sullivans index. Sullivan was the person who, scientist who, this by due to his name, this disability rate is, that it refers to the expectation of life free of disability. Now we minus the disability days from the total life. So Sullivan index is life expectancy of the country minus probable duration of that disability and inability to perform major activities. So it is considered as one of the most advanced indicators currently available. Then is the HALE, that is the HALE is health adjusted life expectancy. So it is base work on the framework of WHO. This is the International Classification of Impairments, Disabilities and Handicaps, ISIDH. And it is based on the life expectancy at birth, but includes an adjustment for time spent in poor health. So it is equivalent number of years in full health that a newborn can expect to live based on current rates of ill health and mortality. You just see the current rates of ill health and mortality, and then to the newborn infant you give the equivalent number of years in full health. Then there is one is DALI, disability adjusted life years. So it is defined as the number of years of healthy life lost due to all causes, whether from premature mortality or disability. It is simplest and the most commonly used measure to find the burden of illness in a defined population and the effectiveness of the interventions. So you need two things, 2 points to measure DALI. One is the life table of that country to measure the losses from premature deaths, and number 2 is the loss of healthy life years resulting from disability. If a person dies earlier than is the expected age of that country, one has to see that life table, and then for measure those days which are this lost due to disability. So the disability may be permanent, like a polio, or temporary, like tuberculosis, leprosy, or any other debilitating disease. And that this also includes any physical and mental disability as well. So the DALI is years of life lost plus the years lost to disability. It's very clear. Then what are the uses of DALIs? To assist in selecting health services priorities, to identify the disadvantaged groups, targeted health interventions, and measuring the result of health interventions, and by providing comparable measures for planning and evaluating programs. And by this, I already told you, and the other indicators of health, we compare the health status of different countries and communities. And one DALI mean one last year of healthy life. Now we discuss the nutritional status indicators. So nutritional status is a positive health indicator. If you have good nutritional status, this indicates positive health. Bad nutrition indicator is a bad sign of, or sign of ill health. So a newborn, you already know, for nutritional status you measure the birth weight, the length of the newborn, the head circumference, and this reflects the maternal nutritional status. A newborn with stunted head growth, lesser birth weight, this will reflect the maternal malnutrition. And then anthropometric measures of preschool children like weight, height, and midterm circumference. So if there is weight loss in the preschool children, this will indicate malnutrition. If there is lesser height, it is chronic malnutrition. And all this midterm circumference, if it is lesser, it also measures chronic malnutrition. And there are the standard charts of measure for all these. Now, there are different standard to be underweight, stunting, wasting, and overweight. This growth monitoring of children is done by measuring weight for age, height for age, weight for height, height and chest circumference, and midterm circumference. And in adults, underweight, obesity, and anemia are generally considered reliable nutritional indicators. Now there are healthcare delivery indicators. These indicators reflect the equity of distribution of health resources in different parts of country and are of provision of healthcare. Now healthcare delivery indicators are population per PHC or primary health center or rural health center, and are the population per sub-center. And then we come to utilization rates. Utilization rates are actual rates is expressed as the proportion of people in need of a service who actually receive it in a given period, usually a year. And it depends upon the availability and accessibility of health services and the attitude of individual towards healthcare system. So the examples of different utilization rates are proportion of infants who are fully immunized, pregnant women who receive ANC, and percentage of population who adopt family planning, and then the bed occupancy ratio, etc. Then is the indicators of social and mental health. These includes rates of suicide, homicide, other crime and traffic accident, juvenile delinquency, school and substance abuse, domestic violence, battered baby syndrome, etc. And it is a guide to social action for improving the health. And this social and mental health of the children, this depends upon their parents. Then are the environmental indicators. These reflect the quality of physical and biological environment in which diseases occur and people live. And these most important measuring of the population having access to safe drinking water and sanitation facilities. And the other indicators are those measuring the population of air and water, radiation, noise population, exposure to toxic substances in food and water. Of course, the food adultery and water adultery is also a very important environmental indicator. Then are the socioeconomic indicators that do not directly measure health, but are important in interpreting health indicators. I told you, muflisi hisse latafat ko mita deti. If someone is poor, he has all the low health budget for him and no education budget for him. So all his life goes into misery. So this is rate of growth of population, per capita gross national income, dependency ratio. All these are socioeconomic conditions. Then are the literacy rates, then the housing, the number of persons living in one room, per capita income or per capita calorie, and the countries with favorable socioeconomic indicators have reported less health-related problems. Then health policy indicators, the single most important indicator of political commitment is allocation of adequate resources. If the adequate resources are allocated for the health budget, it is a good health policy indicator. But unfortunately, in Pakistan, very less proportion of GNP has been spent on health services. Then indicators of quality of life. This life expectancy is no less important. The quality of life has gained its importance. And the physical quality of life index indicator, it consolidates infant mortality, life expectancy and age of 1 year, and literacy. Then is the Human Development Index. It is defined as a compositive index combining indicators representing 3 dimensions. Longevity, how much long life you have, life expectancy at birth, then is education and gross national income. Then there are other indicators. These are social indicators like population, family planning, family and household, learning, education services, learning activities, distribution of income, consumption and accumulation, social security welfare services, health service and nutrition, housing and its environment, public order and safety, and social stratification mobility. All these are marked under other indicators. And then there are basic needs indicators are used by ILO and include calorie consumption, access to water, life expectancy, death due to disease, illiteracy, doctors and nurses per population, rooms per person, and GNP per capita. So all these are in other relatives. And then there are certain health for all indicators for monitoring the progress level of the goal of health for all. By 20,000, WHO has listed 4 categories of these indicators. One is the health policy indicator, that is the political commitment to HFA, resource allocation, degree of equity of distribution of health services, community involvement and organizational framework and managerial processes. Then there are socio and economic indicators related to health. These are rate of population growth, GNP, income distribution, work conditions, adult literacy rate, housing, and food availability. Then third is the indicators for provision of healthcare. It is availability, accessibility, utilization, and the last one is the quality of care. And then there are health status indicators. It is the low birth weight, nutritional status, infant mortality, child mortality, life expectancy, maternal mortality rate, disease specific, morbidity, disability. So these indicators, in this heading, there are certain other indicators which form they are in this group, health status indicators. And then there are certain Millennium Development Goals indicated. These goals were adopted by UNO in year 2000 and it was opportunity for concerned action to improve global health. So MDGs break down 21 quantifiable targets that are measured by 60 indicators. So it's a long list, and then we can say health is not measured directly but using indicators. Indicators should be valid, sensitive, specific, reliable, relevant, and feasible, and used in measuring, describing, comparing, identifying health needs, and planning and evaluation of health services. And now, no single comprehensive indicator of a nation's health. Each available indicator reflects an aspect of health. Search for a single global index of health status is continuous, and the use of multiple indicators arranged in profiles or patterns used to make comparison between areas, religions, and nations. Thank you.